Alright, so this is our fourth PEDS lecture. This is my belly tumors talk. Start out with the this versus that here. So, what we're seeing over here first is too many spleens. So this is a polysplenia case. You notice something weird's going on here, right? And then over here, looks like we don't have a spleen. So this is our asplenia case. So what these are is these are heterotaxia syndromes. Now, when you're looking at heterotaxia syndromes, the majority of the game that is played is this left side versus right side. So what exactly does that mean? So the way that I think about this is by starting first in the lung. So this is a normal picture here, right? So on the right, we've got two fissures, right? We've got a minor fissure and a major fissure. And then on the left, we just got one fissure. So if we're bilateral right-sided, that means we've got a left side that looks like a right side. So you've got two fissures on the left. And if you're bilateral left-sided, that means you've got two left sides. So you have single fissures bilaterally. Now, if we move down into the belly, here's a normal situation, schematically done. Liver on one side, spleen on the other. Two fissures, one fissure, IVC close to the liver, and aorta close to the spleen. So if you're bilateral right-sided, and you say, well, what organ is on the right side of the body? Well, the liver, right? So you've got a liver on both sides. In other words, you don't have a spleen. So your liver sort of stretches across the midline. You don't have a spleen. What did we say was on... so we've got, and then we've got sort of vasculature that's on both sides. So we've got the aorta and the IVC inverting, or reversed. Now, the opposite is this bilateral left-sided. Well, what's on the left? Spleen. So we've got more spleen. So this is a polysplenia situation. And then we've got azygous continuation of the IVC. In other words, the IVC is switched to the other side. So sort of going through this here, right-sided, two fissures on the left side. Left side's going to be one fissure on both sides. Asplenia, because right-sided is a liver, so it's like bilateral liver, so there's no spleen. Left-sided is polysplenia, so it's like a bunch of spleens and no... we'd still have a liver, of course. You can't live without your liver, but it is more left-sided stuff, more spleens. Asplenia is associated with cardiac malformations. And then there's less on the left, and then reversal of the aorta and the IVC with asplenia, and azygous continuation of the IVC with left-sided polysplenia. So, moving on, comparative case here. Now we move into a solid organ. So, both of these things are in the general vicinity of the kidney. One of them has a claw sign, so this is clearly coming out of the kidney. Be a little bit easier if it was shown on a coronal view, but don't expect everything to be easy. And then this one here, not necessarily seeing a kidney, as for the purpose of gamesmanship. If they want you to know it's coming out of the kidney, they're going to show you the kidney. They're going to show you a claw sign. If you don't see a kidney, I would assume that it's not coming out of the kidney. All right, so this is not coming out of the kidney. How do I know it's not coming out of the kidney? Because you didn't show me the kidney. In real life, obviously, I would look at it in all three planes, and I would be able to tell. But just assume that it's not. So if it's not coming out of the kidney and it's a solid mass, it's probably coming out of what? The adrenal. I'll point out a few other differences also. Notice that this is sort of encasing the vessels, and notice that there's calcification. So this is a Wilms tumor versus neuroblastoma. So let's go through some of the differences. Ages, how often they calcify, and invasion features. So Neuroblastoma is seen in a younger person. You can be born with it. That's not true of a Wilms tumor. You cannot be born with a Wilms tumor. The neuroblastoma calcifies more, less than the Wilms. And Wilms tumors are sort of like an RCC in that they like to invade directly into the vein. Neuroblastomas are more like a lymphoma where they like encapsulate stuff. So 90% of the time they calcify, they encase, not invade. They met to the chest and the bones. Remember, we'll talk about lucent metaphyseal bands and lytic lesions in the skull and orbits and stuff. And they tend to be younger, and this is a tumor you can get in utero. That is not true of Wilms. You cannot get them in utero, and it's typically a little bit older. They're more well circumscribed. Think about this sort of like an RCC, invades vessels, and calcification is much less common relative to a neuroblastoma. So I've got two nevers for Wilms. This is for the purpose of multiple choice. One of them I mentioned multiple times. So you can never see it before 2 months of age. Neuroblastomas you can, and you should never biopsy it. And that used to be the case. I think it still is. But the reason is if you biopsy it and it's a cancer, then you're going to seed the tract as you pull the needle back out. So that's a never biopsy. And then there are these Wilms variants, which look just like Wilms tumors, but they're histologically slightly different. And there's two worth knowing, clear cell and rhabdoid. And there's at least one association for the point of trivia that's worth knowing. Clear cell likes to go to bone, and rhabdoid has these rhabdoid brain tumors, which are devastating WHO grade 4 tumors that crush you, and they have a terrible prognosis, and therefore the rhabdoid tumor has the worst prognosis because of it's associated with these brain neoplasms. It's basically a GBM. Now, it's all bullshit because they all come out and you don't biopsy them, so distinguishing between them is irrelevant, but it's a pathologist's problem to tell the difference. But for the purpose of multiple choice, if I show you a renal mass and a 3-year-old with lytic skeletal mets, you're thinking clear cell. Adrenal, remember that, of course, neuroblastoma can go to bone, so that would just be a situation where renal mass plus lytic lesion equals clear cell. All right, next case is this, sort of this rind around the kidneys. We're talking about this thing here, like that. Now, this is nephroblastoma. It can have a couple different appearances. They can look like a homogeneous soft tissue tumor in the kidneys, or it can have this more classic rind. You can be born with this, and it's a nephrogenic rest. It can be a precursor to Wilms tumor. In fact, it's found in 99% of bilateral Wilms. So if you have bilateral Wilms, they probably had nephroblastoma prior to that. All right, so let's do some word association. When I say solid renal tumor of infancy, you say mesoblastic nephroma. When I say solid renal tumor of childhood, you say Wilms disease. When I say extends into the renal pelvis, you say multilocular cystic nephroma. What's the typical age for these things? So they are the Michael Jackson lesion, who does Michael Jackson like, or did he like? He liked young boys and middle-aged women. So it's the same epidemiological trivia for multilocular cystic nephromas. M for Michael. So it's a timing issue, right? So same case, solid tumor in the kidney in an infant, in a 3-year-old, and in a teenager. So in an infant, it's going to be either mesoblastic nephroma or nephroblastoma. In a 3-year-old, it's Wilms or Wilms variant. Can be multilocular cystic nephroma, but that's more cystic. and then you can also get lymphoma at this age. If I had to pick one, it would be Wilms, because that's the solid renal tumor of childhood. In a teenager, RCC is actually the most common, but you can also have lymphoma. Alright, so moving on here. This is just sort of an ant mini. If you have gallstones in an 8-year-old, the answer is sickle cell, right? So kids shouldn't get gallstones. When you see gallstones in a kid, you should think about sickle cell. By the age of 70, or by the age of 30, they pretty much all have gallstones. So now that's the gallbladder. Let's talk about the liver. So again, another timing case. We've got a tumor in the liver of a kid that's less than a year old. So there's a differential for that. It's going to include hemangioendothelioma, hepatoblastoma, and mesenchymal hamartoma. They look a little different. This one specifically is going to be cystic. Now, when you're older than 5, there's also a differential that you have to know. Undifferentiated embryonosarcoma, sort of the nasty cousin to this guy. Fibrolamellar HCC, that's the HCCs that you get in non-cirrhotic patients, tend to have more calcium. And regular old HCC, you can get that as a kid. There's certain predisposing conditions. So let's talk about hepatoblastomas. What's the classic association with these? The classic association is overgrowth syndromes, of which Wilms is associated with, these hemihypertrophies. The classic history for hepatoblastoma is actually precocious puberty. And the reason is because there's a paraneoplastic syndrome with this beta HCG being produced. Just like in HCC, this solid tumor has elevated AFP, and the classic risk factor for hepatoblastoma is prematurity. All right. Classic case here. What if I told you that the heart was structurally normal? Look at that big heart. It's a big heart, but it's structurally normal. There's two situations for this. One is hemangioendothelioma, and the other is a vena Galen malformation. Now, these are high flow states, and so it's a high flow heart failure. That's the reason the heart looks big. Now, the vena Galen malformation isn't actually a vena Galen malformation. It's actually a precursor to the vena of Galen. But I don't think they'd ask that. It's more likely to just show you a picture of it. They can show you an ultrasound, CT with contrast, or MR. Hemangioendothelioma is associated with other hemangiomas, and the Kesselbach-Merritt syndrome, where you've got a consumptive thrombocytopenia, where the platelets are consumed, they're sort of balled up in these big hemangiomas, so you have low platelets as a result. These things tend to calcify and regress, and unlike the hepatoblastoma that had an elevated AFP, these things will have an elevated endothelial vascular growth factor. So mesenchymal hamartoma, this is another tumor that I described as occurring below the age of 1 traditionally, and I said that it's more cystic, right? So that's a classic descriptor, cystic mass in a newborn, less than 1 year old. Is AFP elevated? Nope. Reason is because it's not a real tumor, it's a hamartoma. Some people even call it a developmental anomaly. Does it calcify? We said that hemangioendotheliomas can calcify. No, and that's more of a hepatoblastoma and hemangioendothelioma thing. These things are cystic, they're a little different. So out of those other two solid tumors of the liver and a newborn, this is the one that's cystic. So just a real quick review. So all three of these occur less than 1 year old. This one has elevated AFP. This has elevated vascular growth factor. This has neither. They both can calcify, and this one's associated with high-flow cardiac stuff and other hemangiomas, Kesselbach-Merritt, low platelets. Hepatoblastoma is associated with Wilms tumor with overgrowth syndromes, and it can have precocious puberty. All right, so undifferentiated embryonosarcoma. Remember I said this is sort of the nasty cousin of mesenchymal hamartoma. How do you tell them apart? Well, it's typically older, right? This is older than 5 years old, and it tends to be more aggressive. It can met, it can rupture. So, what about HCCs? Can a kid get HCC, or there are some risk factors for that? Yes. So, biliary atresia, Fanconi syndrome, some glycogen storage diseases. Will your AFP be elevated? Yes, of course, just like in an adult. What if there's calcification there? So that's more typically seen with the fibrolamellar subtype. All right, next case here. So we got a history of prolonged neonatal jaundice. So it's our neonatal jaundice case. All right, so anytime you got that history, you basically have two choices. You've got hepatitis and you've got biliary atresia. Now, how do you distinguish between those two? You do one of these things, which is basically a HIDA scan, right? So what is a HIDA scan? All right, so let's think about, anytime you're doing nuclear medicine, you've got tracers that mimic normal physiology. So here's a red blood cell, and it's starting to get old and old and break down. As it breaks down, it gets eaten by a white blood cell. So your heme gets turned into biliverdin, not biliverdin, and the biliverdin gets converted to bilirubin, which then gets pooped out, attached to some albumin, and this albumin transfers it to the liver, where it ends up getting processed further and pumped through the bile into the small bowel, and then pooped out. So the tracers that are used in nuclear medicine are not bilirubin, but almost. And so you've got a HIDA, right? And then you hook a technetium-99 to it, like that. So now it'll glow hot. You can see it. You can image it with a gamma camera. So now everything pretty much is the same, and it'll get secreted just like bilirubin and get pooped out into the liver. But what if you don't have bile ducts or a common bile duct? Well, then it's going to stay in the liver, right? Just sort of move around in there and put out signal. Now, eventually, you're going to end up being able to remove some bilirubin through the kidney. So that's eventually where it's going to end up happening. So if you see tracer in the bowel, that means you have a bile duct. So you've got hepatitis. And even though it's not going to be normal, just like in an adult, if you were doing a HIDA scan, the hepatic parenchyma is dysfunctional, so it's going to hold on to the tracer a little bit longer, but it will eventually empty into the bowel. No tracer in the bowel equals biliary atresia. So here's some tricks. You need to charge up the liver, and the reason you do this is this like cytochrome whatever system that you want to ramp that up, and that's done with phenobarb, and you dose them 5 milligrams per kilogram for 5 days. So 5 for 5 to keep them alive. And, you're going to need delays, like really delayed, like 24 hours plus, because in neonatal hepatitis, like I said, it's going to hold on to that tracer much longer than you would expect it to. But it will eventually get into the bowel. This is a big decision, right? Because one of these guys is going to get surgery, and one of them is not. So you want to make sure that that is not getting in the bowel for sure. So that's the reason you really want those delays. So biliary atresia is basically no ducts outside, too many ducts inside. Early diagnosis is very important. If they get this Kasai procedure prior to 3 months, they'll end up doing okay, better than dead. If they don't, they will end up with fibrosis. Ultrasound, they could show you an absent gallbladder. That's sort of a classic gamesmanship finding. And there is an association with polysplenia. So you might be asked to biopsy the liver in the setting of biliary atresia. In fact, this is a common thing you can be asked to do. Now, why do you do that? You're asked to do that to exclude this Alagille syndrome, and which is another thing that has it's another absent bile duct thing, but this time, instead of having proliferative bile ducts, which is the case with biliary atresia, remember the atresia is just the external part, they're absent intrahepatic as well. And the classic association with this, which I believe I mentioned in cardiac talks, one of the cardiac talks, is peripheral pulmonary stenosis. So just as a summary, SMA, SMV reversal, malrotation. Absent spleen or polysplenia, heterotaxia. And remember that asplenia is more commonly associated with cyanotic heart disease. Absent gallbladder, biliary atresia. All right, so that's the end of this GI belly tumor talk and GIGU belly tumor talk. And the next talk is a congenital neuro case.